Memphis, we got a state-of-the-art mobile stroke unit with cutting-edge CT technology capable of CT angiography and full 16-slice CT scan that we can perform in the field. And so the benefit of that technology to our community, not individual hospitals, is that, first of all, we can bring stroke expertise to the patient in the field. This is unprecedented. So we can be evaluating stroke patient right there with paramedics and quickly decide if it looks like a stroke or not. And then secondly, without any delays, we can perform head CT, so to rule out hemorrhage, and CT angiography from arch up in just about 4 minutes in the field. And so we can quickly triage the patient as to, do they need clot-busting medicine called TPA? Do they have large vessel occlusion? And if such, we can bypass nearest hospital or even primary stroke centers and go directly to comprehensive stroke centers right from the field, removing all the guesswork if this is the patient with large vessel occlusion or maybe not, that is currently accomplished by some kind of clinical scales based on patient symptoms rather than hard radiological findings from CT angiography. So this is kind of early patient access to stroke expertise, to state-of-the-art imaging, and faster initiation of therapy and delivery to the appropriate institution. And so far, our unit, which is actually the first one to be stationed and integrated fully with Memphis Fire Department. We are actually stationed at the actual fire station. We take shifts like paramedics and firefighters do. We are activated by 911. We respond to the majority of Memphis area because driving distances are quite accessible here. And we were able to deliver across competing institutions and properly triaged patients. In some cases, we even skipped the emergency room and brought patients directly to cath labs, so mechanical thrombectomy can be performed for certain types of stroke. So Memphis Mobile Stroke Unit joined a group of centers worldwide that pioneered this technology. So it started in Berlin and Hamburg in Germany, and the first center in the United States was in Houston, and followed by Cleveland Clinic, Denver, Toledo, and now us. There are also units now in operation in New York City, Phoenix, and soon Los Angeles. So this is the group of centers that pioneered this technology, and so far evidence available shows as following. For the first time, we have consistent opportunity to treat a larger proportion of stroke patients within the first 60 minutes from symptom onset. So time is brain. And before this technology was available, very few patients were ever treated under 60 minutes, just because it takes hospitals up to 60 minutes to work up those patients and give TPA after their arrival to the hospital. So by bringing technology to the field and the fastest treatment times from our arrival to completion of the CT scan and to initiation of TPA now in Memphis is 8 minutes. So instead of 60 minutes in the hospital, 8 minutes in the field. So if you combine that short arrival to treatment time to quick activation and picking up the patients in the field, a larger proportion of patients can receive TPA within the first 60 minutes. And that has been shown in prior studies. So it is feasible to treat very early. Studies also shown it is feasible to treat faster on mobile stroke units than in the hospitals. It can be done safe. So we know that safety is not compromised because experts are evaluating patients in the field and delivering TPA therapy very similar like what they do in their own emergency rooms. And right now we need evidence, and we participate in a multi-center study called BEST MSU, sponsored by PCORI, that would answer the question if this earlier, faster, and safer treatment results in better functional outcomes in 90 days. So we're looking forward to the results that will be done shortly. The future of stroke treatment is in the field as soon as possible because time is brain. Right now, our capability to equip every ambulance out there that could potentially pick up stroke patient is restricted by the weight and the size and the cost of CAT scan. and the need for having an X-ray tech and the expertise to read those images and so forth. But imagine in the future if we have a small, portable, inexpensive device that can quickly say stroke, no stroke, or ideally not only it's a stroke but it's also hemorrhagic or ischemic, and then you can have tele-neurology, tele-radiology kind of capability to look at that, and then paramedics would be calling from the field and saying, I got a stroke patient, which medicine you would like me to give? And in the future, there is no reason why paramedics should not be able to treat those folks in the field with remote access to stroke expertise. But that's in the future when we have those technologies available to us. Until then, it's a CAT scan, and we're trying to make it sustainable even with this technology.